So hello everyone, welcome to today's webinar, the long-term care staffing crisis, facilitated by Irving Stackpole with Laurie Porter, co-founder and CEO of the National Association of Healthcare Assistants, and Dr. Michael Wasserman from the California Association of Long-Term Care Medicine. My name is Romilly Douglas and I will be your moderator today. Before I hand over the microphone to Irving, I have a few housekeeping items to cover about this presentation. First, today's webinar is being recorded and will be made available via email to all participants after the webinar for further review and sharing. All participants will be muted during the presentation today. We'd love to hear from you and we'll be answering questions at the end of the session. If you have a question, please send it through the Ask a Question tab at the bottom of the player on the right-hand side. If we don't get to your question today during the webinar, we'll be sure to follow up afterwards. So without any further delay, I'd like to kick things off by welcoming Irving. Thank you. Irving, over to you.
Thank you, Romilly, and thank you, Laurie and Dr. Wasserman for participating in this program. This is a critical dimension of the healthcare system in the United States and elsewhere that is suffering. And what we hope to do today is to talk about very briefly how we got here. We want to hear from the point of view of the frontline direct care workforce. I've been chastised for referring to it that way, the people who care. So we want to hear from their point of view, and Laurie will offer that. And then Dr. Wasserman will offer data and examples of why leadership matters during this crisis. And overall, what we're going to be doing is looking at practical steps that operators and managers can take to help reduce the problem, mitigate the crisis. So how did we get here? Well, there's convenient lies and harsh truths. And the fact is that this turnover in long-term care has been continuing for many years. There's various sources of data about the churn in long-term care, but it appears that it's at least 100% among the nursing staff and among the certified nursing assistants, and it's a little less among licensed professional nurses. But the fact of the matter is that staffing in long-term care has been considered a revolving door and fungible, exchangeable. The components of care, which are the people, have been considered interchangeable and eminently changeable, with a renewable resource continually available. And that's simply no longer the case. The fact of the matter is that there may not be a system in long-term care at all. The long-term care providers and the long-term care provision in the United States has suffered from ageism in the society. The dominant attitude toward long-term care is highly negative. And there's a debate going on now all of a sudden about whether or not long-term care is a business or an enterprise. It's an interesting discussion, one that we'll have to table for a future webinar. You then add in on top of this the pandemic, which is a precipitating factor, not the causal factor, but precipitating factor, and you have a real difficult situation. I would say you have a crisis. So the real question is, what do we do? What can be done about the situation in staffing in long-term care? We can see that since the public health emergency was declared in February 2020, that the nursing and residential care facilities have lost at least 410,000 workers, probably more. Laurie or Michael may have more updated information. And the question is, well, where are they going? You can see here that the cumulative percentage change in the healthcare employment by setting since the public health emergency was announced. You can see the loss in nursing care facilities and community care operations, and the gains have been, or the less difficult changes have occurred among office, outpatient, home health care, and hospitals. So nursing homes, yet again, residential care facilities, yet again, are at the bottom of the food chain. Then we have, as we were talking about just before we started the program, we have the State of the Union address where the president actually talked about nursing homes. I'll avoid political commentary, but this may be the first time that nursing homes are directly discussed in the State of the Union address. And in the fact sheet that was issued just prior to the State of the Union address, there were 21 recommendations to cover nursing homes. Significant amount of them had to do with staffing. There were calls for increased staffing ratios, increased inspections and increased fines, and a call to lower costs. I don't know how practical that is. I don't know how feasible that is, but this is what the fact sheet called for and the suggestions that were made. So we're going to be seeing more about this certainly in this year. So what can be done? What can operators do? Well, the first is to recruit. The current recruitment models are replays of older legacy models, trolling for candidates. And the second is to retain. The recruitment models haven't necessarily worked very well because there are other options now in most marketplace areas available for low-wage employees. And retention models, retention in nursing homes hasn't been an issue because managers haven't had to care about retention, and now we do. So there are ways to both recruit and retain more effectively, and we'll be talking about that further in another webinar. But with regards to recruitment, this is an example of a typical recruitment ad for a certified nursing assistant. You're all familiar, many of you are familiar with this. Many of you probably have recruitment ads that look like that. Well, my hope is that we will very soon abandon this model of recruitment. And in fact, we should be talking to our targets. We should be talking to the audiences whom we wish to recruit where they are. And where they are on social media. Here is a TikTok ad that I've got up on the screen here. As you can see, it's had 38,800 views as of the point where I loaded this particular image, with 64 comments and 2,000 likes. I'm sure we'd all like to have advertising that's effective. Here's another example of an ad that appeared for CNAs. Love your job and your team members too. The reason that those recruitment messages work better is that the critical ingredient in retaining direct care workforce in long-term care settings are relationships. There's gobs of data about this. It's not necessarily pay, it's relationships. And the challenge for nursing centers is to engage with and listen to frontline workforce. Relationships in many settings are more important than pay. And the single most effective recruitment method that we can employ is our referral system. Most nursing centers that I've talked to, and I've talked to quite a few, the employee referral system is not energized. It's not refreshed. It's not looked at in a novel manner. It's not developed by the people affected by it most, which are the frontline workforce. So the referral system. The second is, why do people leave? In the model of retention, the critical piece is, why are you leaving? Well, there's some people who leave for life cycle issues, lifestyle issues, changes in relocation. But in every case, we should be asking, When people leave, will you recommend? Would you recommend? Would you refer people? And if they wouldn't, we should understand why, because that is an extraordinarily telling question. And then there's three things that the government can and should do. First is data, data, data. More isn't always equal to quality. We should intervene. It's my personal belief that government can and could intervene to stop recruitment bonuses, which is just a race to the bottom in most marketplace areas. The governments can, through local agencies like the Medicaid agency, State Department of Health, can enlist the cooperation and collaboration of agencies to build job banks, to cooperate and coordinate staffing instead of having wars and battles inside of a particular marketplace area. And then finally, creating sustainable careers. So with that, and I know that I've talked about quite a few things, with that, I'd like to turn it over to Lori, where she can discuss with you the caregiver, direct caregiver, care workers point of view.
Well, thank you, Irving. And I don't have any slides to share with the group today because I'm here to talk about, if you would like, Irving, your "How did we get here" slide was really about what I'm going to talk about and where we go from here in a more floor level frontline view. Because one of the things that has been difficult for CNAs is the fact that every well-meaning person thinks they know what's best for CNAs. And no one ever bothers. And one of the things is, if you put people in a box for 4 decades and then you ask them what they'd like, they have no idea. They've been in a box. They didn't realize they had an opportunity to choose. I'll give you an example. CNAs see their titles change over marketing ploys, marketing schemes of the companies or the facilities they work for. Nowhere else in healthcare are CNAs so undervalued, but at a nursing home. So instead of us telling and preaching and banging on management of how they can do better or what they should be like, because not everybody's a lovey, touchy, feely person. And I love the spot about business or enterprise. When I speak to administrators, and I'm a former administrator, so I kind of see this from all sides, from a CNA, from a dishwasher, from a housekeeper, from a med tech, from a nursing home administrator, and a regional operations director. So I've spent 42 years looking at this from about every angle, and long-term care is the only place my members, for 27 years, I've ran this association of CNAs across the nation, and my hospice members, my home care members, my PACE members, my even assisted living are happier than they are in skilled nursing. So I think we should be asking questions of the leadership is, what's preventing you from building these relationships? You see, I never used a business skill. When you're most people don't realize that an administrator in the United States of America of a nursing home can't make a $500 decision without calling up Chain. So we held our summit, as you know, last week, and this is, I'm going to give you an example of something so simple that may be, and not to take anything away from you or Dr. Wasserman, but it is the simple things, right? It's not academia, and you know, it's helpful. Data and research are not to be lessened, but this is a simple problem of why we can't treat people right in nursing homes. There's a reason, because as an administrator, my staff said I didn't treat them right. And you won't find a bigger CNA advocate in the United States of America, I don't think, than myself. And so if they did that to me, right? Oh, we never get any recognition around here. That's painful. But you know who you're hearing that from? The 5 people you wish you didn't have on staff anyway. And we have been for 3 decades at least, we have not been able to even practice our disciplinary procedures because we're so desperate for staff. CNAs have been running amok and for many, many years now of, they've been in control of the narrative in terms of what happens on a daily basis in a facility. Let's look at this. CMS requires every facility to have a disaster plan. They have one for every disaster that happens in their part of the United States, whether it's hurricane, tornado, required, but they never have to be required to have a plan for the disaster that happens every day, and that disaster is called staffing. So right now, I like to give people some things they can take away and also look to where we're going in the future. But CNA is a profession. It's not to be called a valet. It's not a direct care worker. That's not a profession. If doctors were called direct care workers, it wouldn't be prestigious to be a doctor. I tell my members, I tell them to dress in whites still. I tell them to wear stethoscopes, lab coats, and gait belts. One CNA said to me, if I dress like that when I go pump my gas at night, the attendant's going to say, what are you, a doctor? And I said, what am I supposed to say? He said. I said, here's exactly what you say. No, sir, I am not a doctor. I'm more important than the doctor. You see, I work down at ABC Care Center. They're only required to see the doctor once a month. They have to see us every day. We're more important than the doctor. There's no measurements that'll let a CNA know if they're doing a good job or a bad job because long-term care historically has not done timely evaluations for their employees. So there's no way to know if you're valued or not. Group praise has always been what nursing homes use to recognize their staff, and group praise is a big failing proposition. Sometimes it's great, but not if you're going to tell the team in front of you that I couldn't run the place without you. This deficiency-free survey is yours, baby, yours. And they sit there like, huh? We were told not even to speak to the surveyors. We were told not even to speak to the families. This is marginalizing people who know more about the resident than anyone. It's not marginalizing, it's controlling. There's no marginalization to it. It's let's control them. And so everything we ever did when I was a CNA, and everything I'm hearing from my members is many of them, the reason the exodus is they can no longer stand the human suffering. They know that things are fudged in documentation often, but no one will believe them. They know the inside secrets. They're the eyes and ears of the residents, but they won't even tell those neglect stories because they've been told it's their fault, your fault they're neglected, right? You're the enemy. So CNAs carry a lot of baggage most people don't even know. And you're right, money was never the top #1 spot until the pandemic. And since we're in a mutual business with government, this enterprise or whatever we want to call it, and the greatest skill a nursing home administrator needs is relationship building, not business. You're given your budget. You're given how many people you're supposed to have live there. You're told you can't have overtime, right? You're given all these parameters, but here's the simple thing that came up on that summit. And I hope we have some administrators today attending, because an administrator asked in the chat, if I can't control your wages, if I can't give you a raise, and I cannot give you better benefits, what can I do? Do either of you have any idea what the CNA said? Tell us how hard you fought for us. That's it. That's it. And they can't make that connection to share that kind of information because they're in a box. Nowhere else is there as much negativity in healthcare as there is inside the walls of a nursing home. We have beat the staff from the marvelous dishwashers and dietary attendants we have to leadership, and we've always made it about leadership needs to do better, leadership needs to change. And that's always part of the problem, because if everything's hanging on the leader, this has been 20 years ago, so it's okay for me to say it. The company doesn't exist, but I won't name it anyway. One of the largest chains in the nation back in the 80s and 90s spent 12 or 14 million dollars to bring every administrator and executive director to St. Louis, Missouri, to be trained by the very Stephen Covey himself. I said to the CEO, was bragging to, oh, we've done this. And I said, really? Are you not smart enough that no, half of them aren't going to work for you in 6 months? Why didn't you put the 14 million in the 2,000 CNAs you've had working for you over 15 years? They've shown staying power. CNAs will stay. They will leave less than administrators. They have better work ethic oftentimes than anyone in the profession. But you cannot continue to care when it appears others don't, and you're flying blindly and trying to care for residents. So what we've worked on in the last few years in this is creating CNA design models that are not impacted by an administrator change, a facility sale. The residents' lives can't be hanging in the balance for these type changes. CNAs are ADL specialists. And there's no administrator on the planet, no physician, medical director, no anyone that can come in and change ADLs. So why are we letting this big team inside a facility be a punching bag rather than trying to figure out new design models? We have 15,000 facilities across this nation in varying degrees of physical plans. Many people want to see small houses. I'm not against small houses, but that's not a solution, because nobody's going to tear down these 15,000 old buildings, right? So you put a policy paper together with four asks, and one of them is small houses. It's dead on arrival. What do we want to fix in this? And I believe staffing, the reason you're holding this is because we can no longer, CNAs must be paid. I'm watching things go in the opposite direction. I saw today, Florida's closer to having their hours reduced to 1.0 CNA hours. TNA program is just applauded over and over by the industry. How can you be a skilled facility and not have skilled labor? We should not be reducing standards at this time, because that's why we've lost people. Home care, hospice, hospitals, they have standards and processes that nursing homes simply do not have. And I don't believe we ever have. We've all been flying by the seat of our pants. So when I go back to the staffing disaster, here's another little simple thing. Imagine if the administrator just said, I have told them I have over 400 collective hours experience among our CNAs. Yes, I fought for you. That's a win, simple win. Okay, so we now have this business of how every administrator is trying so desperately to recruit. They have no business recruiting. You see the experts on the outside of long-term care. That's what the commission report was about, how the exterior, the parameter of long-term care can come together to fix this. These are simple problems to fix. They truly are. So what do CNAs really want? You can't recruit them to do, many of you know we started a school, an online platform called the National Institute of CNA Excellence. Do you know what our #1 challenge is? Mike does. I don't know, Irving, if you do, and I'm certain our audience doesn't know. But to get to hire one of our graduates, a long-term care facility has to be able to identify 2 CNAs in-house to have become preceptors through our program. We have 300 facilities signed up, and none of them can get to compliance. There's no shortage of people who will want to become CNAs, but you have to know what the right message is. And I love your TikTok ideas, but I also think this CNAs are treated like children, and we really, really resent that. The gold star you get when you get to, you get 5 gold stars, you get to go to the administrator's office and get a candy bar. Are you serious? Is that as inventive as we can get?
Hope
And then, there's been a lot of jokes about pizza parties. And we chimed in on that too until one of my board members said to me, hey, I know that we make a joke about that, but I know some CNAs, that's the only meal they're getting. Now we can continue to treat them like they're beneath us. We can continue to treat them that they're not worthy or they're not smart enough. And we'll continue to get what we've been getting, which is very little. And we will lose all of our decades-long experienced CNAs. I've lost 2 off my board that have one left healthcare altogether after 22 years and another one went to hospital, where she says the nurses fight over getting to work with her. So you see, we have to create these systems that work inside other institutions where you're valued. Instead of trying to take the C away from nurse aides, they never change. They'll say, people will call me and say, we want to change the name of the CNAs. What do you think about care valet? I said, what are you changing the RNs to? Well, we're not. What are you changing the LPNs to? Well, we're not. Then why in the H would you change the CNAs? They're proud of that. Now, OBRA, we can go clear back to there because that was my first year as an administrator was 1989, and I ushered in the 10-190 OBRA, giving nursing homes the ability to teach the class. Well, there went the profession right there, fellas. Go back and look. You can trace it to OBRA. When we allowed facilities who weren't that organized to begin with to try to develop talent, professional talent. So there's a lesson to be learned here. You get what you pay for. And that's all there is to it. You get what you pay for. And they've been very fortunate over these decades to be held together by CNAs that have stayed no matter what. But at some point in time, when your nurse doesn't seem to care, your administrator doesn't, how in the world can you continue to care? So my big question, if anyone could ever answer it, is what do administrators think they can do to become relationship builders? Because you have to have one with the families, the residents, the vendors, the community you live in as a marketing person. These are all the skills. So there is now some momentum. And not to get controversial, I won't speak on it, but there's some momentum now to go back to the way I came up. You see, when I was a young administrator, there were many who did it the same way I did. An AIT program in the 80s meant you went to live somewhere on a campus for 2 or 3 years to be 6 months in dietary. You didn't have to have a college degree. And frankly, I would have been insulted had I had to have one because it would have never been utilized in my daily work. If anything, social work is more to the type of what an administrator skill set needs to be. Because of the need, nothing is more important than relationships, and that's what CNAs focus on. So in my end, which I've probably taken too much time already, but I will close with this. CNAs are our greatest talent. They'll carry long-term care to the future. And without focusing on this area, we're dead in the water. Our residents don't stand a snowball's chance if we can't figure this thing out, and it's not rocket science to treat people as professionals. We have 2 models with nursing and physicians. We should be able to follow that model with certified nursing assistants.
Amen, Lori. Thank you so much. Great job. Certainly stirred the juices, stirred the pot. Michael has some observations about leadership. So without further ado, I think Dr. Wasserman is looking for his deck.
Is it there? Does it see it?
I can see your slide, so let's give it a shot.
Okay. So thank you. I could listen to Lori all day.
Me too.
You know, I want to start with something positive, and I love to tell stories. And a few years ago, when I was running a large nursing home chain, I got in my car over 6 weeks and literally personally visited 74 facilities seeking out the CNAs. And I love to tell this story because it just reinforced something that Lori's just talked about. These are not only incredible human beings, but they love what they do. And she's right about the 5 people who don't love what they do, who want to complain. But the reality is there's a ton of folks working in nursing homes who love what they do and to me have the highest degree of compassion of anyone in the healthcare industry. So I think it's important to point that out. I think Irving talked about leadership. I'm going to talk about leadership. Lori talked about leadership. The other thing I did learn, and I think it'll resonate with all administrative folks on this webinar, if you have a facility with poor culture and poor leadership, a CNA will go to another facility for 25 to 50 cents. If you have a facility that has great culture, great leadership, it's closer to $2. Now, that doesn't mean that those dollar amounts are right or wrong. I'm going to talk about that a little bit, and it doesn't mean we don't value CNAs. Valuing them matters, but so does respect. And I think to that point, I'm going to talk about leadership, and I'm going to start with the concept of leadership models. And I like to do this because it defines things. And also, over my career as a geriatrician, folks are always saying, well, what data do you have? Well, you know, Lori can talk from an experiential perspective. I can talk from an experiential perspective. But how about some data? And I'm going to share some data with you. So one of the leadership models that defines some of the data is the 3 types of leadership being transformational, transactional, and passive avoidant, where transformational is motivational and passive avoidant is essentially an absence of leadership. And so, let me see, oh, there we go. So transformational leadership is the type of leadership where you increase levels of motivation, you inspire people, they go above and beyond. It's also based on studies in nursing homes associated with increased well-being from staff, increased feelings, increased job satisfaction, decreased intention to leave, decreased burnout rates. From a health outcome for nursing homes, it's also associated with higher patient satisfaction, higher quality of care, lower mortality, fewer medication errors. I mean, if this were a medication, you know, who wouldn't use this? And so in one study on transformational leadership styles versus passive avoidant, head nurses and DONs scored significantly lower on transformational and transactional leadership styles and significantly higher on passive avoidant leadership styles. And then we ask ourselves, why do we have 100% turnover? Well, there is a correlation that goes directly back to leadership, and the data shows us that it does. So with that, I want to introduce another description of leadership types developed by Vinoma Slevin. It's consensus management style, which actually leans more towards a servant leadership style. The consultative autocrat, the autocrat, and the shareholder manager. And you know, Lori's point about a lot of nursing home administrators are just given their budget and really don't have the opportunity to make any changes. I would actually lean into changing that. I think even if we provide great leadership, if essentially the CEO of an incredibly complex business or mini hospital can't have flexibility on their budget, I'm not sure how you make it work. But maybe that's for the Q&A or for another webinar. Not surprisingly, this study was done a decade ago, but it's still, I'm sure it holds true. 70% of nursing homes had administrators and DONs who met the autocratic and shareholder management style, and only 30% were consensus style leaders. Now, why does that matter? Lori was talking about the type of leaders we need, the type of leaders who interact with their CNAs, who walk the floors regularly, who hear the concerns of their CNAs and include them in helping to develop solutions to problems and issues. And as she said, who will go fight for them with ownership in terms of pay and things like that. Okay, this study was done a decade ago. In facilities that had consensus style leadership, there was significantly lower staff turnover. And so while everyone's talking about how do we reduce staff turnover, the data shows one of the ways of doing it is to have consensus style leaders. But let's go one step further. How about healthcare outcomes? The same study, and this study was on a couple thousand, if not more, nursing homes in the United States. So this was not a small study. This was a large study. Still boggles my mind that this study has never gotten more play or interest because it's profound. Lower restraints, less pain, lower pressure sores, lower use of urinary catheters, higher 5-star QMs, higher 5-star inspection scores. That's what transformational consensus style leadership in nursing homes brings: lower staff turnover, improve quality outcomes. What's not to like? What's not to implement? And you know, that's the question I would pose. And I always close every talk I give with a photo of my dad, and everyone thinks that's Albert Einstein, but my father's actually an Albert Einstein lookalike. He's 88 years old. He embodies positive aging by going to the batting cages every week to hit 90-mile-an-hour fastballs. I got to get in my anti-ageism plug. And with that, I guess we can go to the Q&As.
Well, thank you, Mike. Thank you, Michael. Thank you, Lori. We've covered a tremendous amount of ground, and I see that we have some very good questions that I would like to ask if Romilly's got them queued up. One of the questions is just a technical question about, yes, everyone will get, I believe everyone will get a copy of the presentations, and Dr. Wasserman and I talked about the need for having references, so there'll be citations attached. So yes, those of you who want to do that kind of academic stuff,
Yes.
We're in there with you. And those of you who want to have conversations about relationships, we're in there with you too. So can you queue up some questions for us, Romilly?
Yes, I sure can. And I just want to say thank you to our speakers here today, Dr. Michael and Laurie. That was so informative, both of you. Thank you very much. So let's dig up some questions here. So this is a wide question. So how can we combat the staffing crisis in at-home care?
At-home care?
Yeah,
Yeah.
in at-home care. Why don't you start with that, Lori?
Well, number one, you know, to me, that would be, we have so much easier time recruiting for those areas. But typically when you know you have a caregiver's soul, you need to be sending messages around the value of the patient, what your commitment is to the patient, your mission statement. And of course, people do look for pay these days. But the heart of a CNA, the heart of caregivers, it is the heart more than anything. So here's, you know, if you can articulate your mission in a way that other people can articulate it within the company, it will go a long way to send messages to prospective employees of what their role and responsibility is and the value of it.
You know what, I would add that the need for CNAs across all of long-term care. And when I talk long-term care, nursing homes, assisted living facilities, group homes, and in-home long-term care, which a lot of folks have needs for. And I think we need a huge increase in CNAs across the board, across the country. So I think this all fits in with that. I think it's a great question. I think we need a nationwide mission to grow this workforce as the population continues to age. And despite the blip that COVID has caused in the 85 and above population, that historically in the last few decades has been the most rapidly growing segment of our country. And so we're going to have needs for CNAs across all of long-term care, and I think we must all focus on it.
It's clear that the demand is going to be there, the need is there. One of the things that we've discovered through our research is that the psychographic profile of a person who prefers to work in a nursing home or a hospital is very different. And the psychographic profile of an individual who prefers an at-home setting is also distinct. And our recruitment in the past, for decades now, has not differentiated effectively. Certain companies who've invested in the research and understand profiling do a better job at this, but they are not the same person. You can lure someone out of a hospital setting to work in an at-home setting by offering them lots of money. We would call those job hoppers. And the bad news about hoppers is that they can hop away as easily as they can hop in. So for at-home care, it's important to understand who your market is. And the difficulty at this time is, of course, competing against options that are being offered in marketplace areas such as Amazon and other entry-level employment situations that pay more. So we have to, I believe, to what Lori said, need to focus on the mission. Why someone wants to do this work is profoundly different from whether or not they will do the work. And we need to focus more on that, I believe.
Leaders fail to communicate their vision to their teams every day in our profession, right?
I get it.
And so, you know, every facility, I'm a sports person. I mean, I was when I don't like to watch it. I always enjoyed playing it, but I happened to be the point guard, and we didn't keep running play 2 as I dribbled down the court if 2 was getting shut down, right? So we had to have multiple plays in our playbook, and that's what, so selling that vision is one of the most important, because people who care want to know where you want to lead us, right? How can you be a leader without sharing a vision?
That leads me very nicely to the next question, which is, I'm curious to know how staff development impacts staff retention and recruitment.
Immensely, in my experience. We have what's sad to me is, as a professional association of CNAs, that they have to pay for their own education they get through us because it's not sponsored. CNAs are given 12 hours of compliance education, which is nothing more than a checkbox. That is not important, valued education by them. However, we have, I'll just for reference, in 2019, we had over 79,000 hours of continuing education going far beyond compliance completed by CNAs in this country who were willing to pay for it out of their own pocket. So continuing education does matter. They want it desperately, but they're insulted by the current platform of compliance for the last 40 years about a checkbox.
Right. I completely agree with you. And we have quite a bit of data. So the question was interesting because it sort of conflated retention and recruitment. Staff development is really relevant for retention and not necessarily for recruitment. The dimensions associated with why someone takes a job are quite distinct from the dimensions as to why somebody keeps a job. And interestingly, poor onboarding is very highly correlated with willingness to leave. with willingness to look at or take another job. So poor onboarding, which I would include staff development, because if you're doing a good job of onboarding, that includes good staff development. You wanted to add something, Michael?
Yeah, you know, so California Association of Long-Term Care Medicine has a leadership and management training program for nursing homes where we bring together the leadership team. And I'm a huge proponent that an administrator alone cannot successfully run and manage a nursing home. It is a team, and that team, the definition of that team to me has always been the administrator, the DON, the medical director, and the director of staff development. And I actually think the director of staff development plays an incredibly important role and needs to be included and not just sort of set aside and siloed and told what to do, because it takes a team, it takes an interaction. The last person who's now probably because of COVID needs to be involved in that team is the infection preventionist who has a role now that should embody ongoing education and training on a daily basis of all staff. So, but I think the role of that director of staff development is absolutely essential.
Agreed.
Great. I've got a couple of more interesting questions if you guys are interested. So, what suggestions do you have for a company, excuse me, who has reviewed and increased wages for nursing staff twice and given multiple bonuses over the last 2 years to show our appreciation? Yet we still have staff upset because there are rules in place that they must follow and they don't like disciplinary action. We still have CMS regulations to follow. So what can we do to help?
I'm going to jump in on that one. And I've heard this so many times. And look, I think it's easy, and I think we've all said it. If you just increase pay and you don't demonstrate your appreciation of the value of your staff and demonstrate the respect, and that all does come back to leadership. And I think if you're getting that response, each and every member of that team needs to look in the mirror and say, do we just, you know, are we blaming the staff, or do we need to look at how we are treating them and how we are acting as leaders? And I would strongly suggest that the leadership and management skills of the frontline leadership in nursing homes needs to be upgraded. I think to ignore leadership training, and that's why I showed all the data on consensus style and transformational style leadership, and also the data that it doesn't exist to a large degree. So
yeah.
To Lori's point, you know, doing the same thing over and over again and looking for looking for different results is the definition of insanity. I think we all have to look in the mirror and say, what more can we do? And I think part of that answer is leadership.
If I can add just one thing that I have found that is incredibly frustrating when I consult facilities, because there are solutions, workforce design models to implement that completely wipe out CNA turnover, completely wipe out agency, except for the turnover that's the healthy kind, right? Which is not what we're talking about here today.
Right.
Is to give CNAs an opportunity to be a bigger role, play a bigger role, right? And there's plenty of roles to be played that are uncovered in a facility right now. So it kind of like the disaster plan. Everybody says they'll help, but CNAs say no one will help. Well, why let that fester for decades? Have a role. You're play 3. Dietary's going to do this today because the flag's red. Housekeeping's going to move into this position because this is the way it is. Because then you've got a team that's willing to jump in and help and create that team atmosphere. And I forgot what the original question was, but that just made me think of that. So
actually, can I add one thing more to Lori's comment? I'm a huge believer in QAPI, quality assurance, performance improvement, as we all know it from CNAs. But the vast majority of nursing homes in this country do paper compliance to QAPI, and a DON or someone else fills out the form and does it. That is not QAPI. QAPI is a team getting together and doing quality improvement.
Right.
And one of the key people on that team is the CNA. So I ask your facilities, how many of you have CNAs actively involved in your QAPI teams and your QAPI processes? And everybody on a QAPI team is equal. There's no leader of that team. There's no one who deserves more respect or less respect than anyone else. And if I were going to choose one thing to operationalize from what Lori said about giving CNAs something to be involved with, if your CNAs are not involved in QAPI, you're missing a huge opportunity.
This is so evident, Michael, in the quality awards at a national level. Those organizations that are successful in achieving silver and gold standard quality awards demonstrate substantially higher levels of interaction and cooperation. So my feedback on this goes back to the language of the question, because the language of the question uses an us-them language. And I would submit to you, maybe I don't want to put too fine a point on it, but I would submit to you that's part of the problem. That indeed,
Absolutely.
The nurses are able to understand compliance with CMS regulations. If we can't have a conversation in an organizational development training, even just call it communications, in a communications environment, then why? If because you believe that command and control is the model to use and they should just comply, and everything would be fine if only they would do. No, that's
Well, the average facility in this country right now has no means, given the technology that's available to us. I wouldn't be an administrator today if I couldn't, with one push notification,
it doesn't
to every
exist.
staff member I have. And even the staffing scheduling models out there that have all these tools built into them, facilities are not utilizing. One of them that we have to mention is the fact of how is your shift? They have a built-in, how was your shift? And people that own and operate nursing homes do not want to know, because they already know, right? We don't need more data on that. But inclusion, us versus them, has been the problem all along, right? But neither understand each other.
Doesn't it? The respect.
Certainly one of the background issues. Thanks, Lori.
So we might end on this question. Let's see where it goes. Do you see electronic health records contributing to staff burnout and dissatisfaction? For instance, do staff resent complex, rigid systems that take too much time and keeping them from doing actual caregiving work?
Depends how it's sold to them.
Yes. Well,
if it's a chore and if it's a part of sustaining life, they'll understand that. If it's put out as a chore, they'll resent it.
So long-term care is the land that technology left behind.
Or they didn't go for technology.
We were specifically excluded from legislation and regulations that promulgated electronic health records. Meaningful use has no meaningful results in long-term care. Home care's got good technology because the government required it. Long-term care is the land that technology left behind. Grocery stores have better technology than nursing homes, and that's just a fact. And one of the reasons for that is that the owner-operators have not demanded more from the vendors. The idea that you're going to improve a CNA's life by giving her a kiosk tablet that's screwed to a wall so nobody can steal it, and that he or she has to then walk out to the tablet and instead of and look on a slip of paper and put into the tab, you've just increased the opportunities for errors. In a real CQI, continuous quality improvement environment, you have actually introduced opportunities for error. So what we need is we need seamless ambient technologies. And the good news is that because we don't have really a healthcare information technology infrastructure in long-term care, we could probably get there less in fewer leaps. But there needs to be investment in infrastructure. And that's one of the things that I was sadly disappointed with the White House fact sheet. There was no call for that investment, no methodologies suggested or pointed to as to how that investment would occur.
I'll make 2 comments on this. This is something near and dear to my heart. Electronic records across the board historically are billing centric.
Sure.
So we need care-centric electronic health records, number 1. But number 2, and I'm glad Irving mentioned grocery stores, because Amazon has grocery stores where you can walk in, get your groceries and leave without ever going through any aisle because they have sensors, they have technology. I don't know why the future of long-term care isn't that CNAs and nurses and doctors go about their day, the CNAs change the residents, do all they can, and everything is captured so that they don't have to go sit in a dark corner of, with a tablet at the end of the day and try to remember what they did. The technology exists and we're not using it. So that's really the bottom line.
Amen.
It does scare long-term care a little bit, though, to have more information out there than what they can control the narrative of. Let's
now that's an interesting point, Laurie. We should
that's
save
what I
that for
mean
another
about they don't
conversation.
want to know how their shift went, because somebody could report that analytic out of their control. Exactly.
Okay.
Do we have time for one more, or should we wrap it up?
One more quick one.
Great, let's do that. Okay, so what do residents and families do when long-term care facilities say they are staffed just fine? Excuse me, I'm sorry, that's a really badly written question, and I didn't read it before I read it to you.
I think what they're trying to get
at
is,
what do residents and families do when long-term care facilities say that they are restricted because of visitations due to staffing?
So there's 2 components to that question, I think. One is the recent experience of families has to do with visitation restrictions, which is distinct from, that's a public health issue that's probably not been managed properly, but some have. Some centers have managed it very well. And the other part of it is that, oh, we don't have the staff. I'm sorry we didn't get to mom's bedsheet change because we're understaffed. My personal take on this, and I'd be keen to hear Laurie's, my personal take on this is that families only know that the center is understaffed because the staff tell them that the center is understaffed. Now, there's some obvious things, and certainly with 100% turnover and losing almost 500,000 workers, there are some obvious things that are occurring that people can see. But this dynamic, this negative dynamic of talking about understaffing, blaming understaffing, I'm not saying that that's not correct, but it is an extraordinarily negative cycle that needs to get addressed. What's your take on that, Laurie?
Oh, Irving, goodness. You know I can't be quick. That's the problem. You set me up with these unbelievable.
They're real questions. That's why we're here today, I think.
Well, it is, and I got lost in what you were talking about. But the information that needs to come out from nursing homes is not the information that's put out. If we stop and think about it, you know, CMS has a reason for collecting the data they do, but it is wholly insufficient to what the consumer needs. That data is not helpful to a consumer and neither is the 5-star system, because if you'll remember the facility, Kirkland, wasn't it, that where COVID first appeared? They were 5-star deficiency free a few weeks earlier. And then they got hit with a $700,000 fine or something like that. So, you know, the investment in long-term care, I've said recently that 2 things are true. Reimbursement has never paid for quality care. It pays for minimum care. And, you know, going back to sports, I've never seen LeBron James support minimum, right? We're minimum, brothers, we're minimum. We knocked it out minimally. Get a banner, get the banner hung, get maintenance, get that banner up right away, right away. We're deficiency free. All that means is minimum. It's time for long-term care and the government to go far beyond compliance, because they're in this together, and that's the only fix there is. Facilities can't afford to pay the kind of money CNAs require now. Every facility deserves to get $22 an hour out in quality if that's what they're willing to pay. The problem is, if we don't create systems of accomplishment, a poorly performing CNA makes the same as an excellent performing CNA, and that is a very big downer. So I don't know if that was the answer, but I just see many, many solutions that if nursing homes will quit pointing fingers and the government pointing fingers at one, that's the holding pattern. So we must progress, and we must educate the consumer so that they will know how to follow along to what is a good facility and not. But to have a 5-star facility deficiency free with a 2-star staff, to me, is the big headline, because that's why there's been no investment. If you can be perfect according to the government, 5-star deficiency free, but your staff rating is a 2, what more do any of us need to know? That staffing's not important in this area, apparently. Well, it is to us.
There's something wrong with the rating system too,
exactly.
Clearly.
Irving, I have a quick analogy if you have just 1 minute.
Okay.
So if you're in an airplane at 10,000 feet and someone hands you a parachute, but they say, you know, we don't have enough textile workers, so only half the parachute has been built. Will you take it and jump out anyway? And who's going to say yes? No one is. And yet everyone wants to talk and complain that we don't have enough staff. That's not the issue. The issue is we know that when we don't have enough staff, we have lower quality. And so that narrative should not even be out there right now. I have to say, when everyone moves to, well, we don't have enough staff, that's like, well, we're jumping out of the airplane with half a parachute, and that's okay. And I don't accept it.
We're going to have another conversation about that, Michael. Thank you, Lori. Thank you, Dr. Wasserman. Thank you, Lori Porter. This is terrific. Thank you, Romilly. And for all of those who hung in here with us to the end, thank you all very much, and have a great day. The conversation is far from over. We will continue.
Yes, thank you all for attending today's webinar. We hope you found it informative. And when this is over, please take a brief moment to tell us how we did. You'll be asked to fill in a very brief survey, and this is the way that we can learn how to improve our presentations. Thank you again, and we look forward to seeing you at the next webinar in May, and some information on that will follow shortly. So have a great afternoon, day, and stay well, everyone. Thank you, Laurie and Michael. Thank you, Irving.